Good evening, all. You are all welcome to this session of our presentation, which is going to be a case presentation of a patient who presented with features that are suggestive of rectal cancer, and he was clerked, and the history and examination will be presented so that you see a template on how to take a detailed history on a patient who presents with symptoms that are suggestive of rectal cancer or colon cancer in general. Okay, so we are going to take the history, then we will discuss common questions that follow long case presentations. Okay, so just a brief revision on history taking before we go into the history of this patient. We are supposed to know that when you are taking a detailed history, you follow the usual pattern of creating a rapport with patients. You start by creating a rapport with patients. Next, you take the biodata of the patient. The presenting complaint, the history of presenting complaint, okay? Past medical history, family and social history. Drug history, history of allergy, summary. So let's start with the history. Now, after taking this history of a classical rectal tumor, we would throw more light on history taking generally. And if you have questions and clarifications, you will ask. So I'll commence the presentation, you pay attention, then subsequently, I will now explain in more details on how the organization of the history goes. Now, my patient is Mr. Umar Abba, a 65-year-old farmer, Hausa by tribe and a Muslim, who lives at Garko local government of Kano State. He presented with a complaint of change in bowel habit and bleeding per rectum of 18 months duration. He was apparently well until 18 months ago when he developed change in bowel habit, characterized as constipation alternating with diarrhea. The constipation is for about 3 to 5 days, as opposed his previous once daily passage of stool with passage of pellets and pencil-like stool. The constipation is then followed with diarrhea and passage of spurious diarrhea. There is associated tenesmus, which is so frequent to disrupt his routine activities. At about the same time, he noticed bleeding per rectum of bright red blood, which coats the surface of the stool. No passage of clot. Since onset, there is associated progressive weight loss, easy fatigability, and anorexia. No abdominal distension, pain or bilous vomiting. No anal pain, protrusion, or fecal incontinence. No perianal discharge of feces or flatus. No history of fecoluria or pneumaturia. No flank pain, swelling, or fever. No jaundice, no cough, chest pain, or difficulty in breathing, as has occasional palpitation and dizziness. No back pain or bone pain. No headaches or convulsions. No history of rectal bleeding in the past or colonoscopies. No family history of similar problems, colonic, ovarian, breast cancer, or gastric cancer. No exposure to radiation. Diet is predominantly cereal-based, does not smoke or ingest alcohol. No contact with chronically coughing adults or drenching night sweat. Okay. Involved in irrigation farming, no childhood hematuria. No history of diarrhea associated with febrile episodes or frothy diarrhea. Not a known hypertensive or diabetic or asthmatic. No previous surgeries or blood transfusions. Since onset of symptoms, he attended general surgery outpatient department 2 times where some blood radiological investigation and colonoscopy were requested, and the details of results not fully known to patient, and was admitted for surgery. He's married to a wife with 10 children, no known drug allergy. In summary, I just presented a 65-year-old farmer who presented with alteration in bowel habit, tenesmus, bleeding parectum with associated progressive weight loss, dizziness, palpitation, and easy fatigability. Okay, so this is the history. Before we go to the examination, I will just give a small summary on how the structure of history should go when you are presenting a long case. Now, coming to the beginning of this history, okay? Now, of course, when you create rapport with a patient at the bedside, you greet the patient, you introduce yourself, and seek for permission to commence history taking in the patient. And of course, you explain to the patient that you are partaking in an exams. So most of what you say or do might not influence the treatment of the patient. So he should relax and cooperate with you. Of course, we all know after creating rapport, you take the biodata, which is summary is Nastroma, okay, where you describe the name of the patient, age, sex, tribe, religion, occupation, marital status, and the address of the patient. Sometimes not all these will feature in the biodata. Some of these features might be in the body of the history. Okay, now let's go to the history of presenting complaint. The history of presenting complaint must have a duration. And usually when you are outlining the history of presenting complaint, the first symptom should be mentioned in order of occurrence. The first symptom that was first noticed should be the one to be presented. But however, in this particular patient, both change in bowel habits and bleeding parectum occurred at the same time. If, for example, the change in bowel habit was there for 18 months and the bleeding parectum surfaced later, maybe in 5 months, so your presenting complaint will be change in bowel habits of 18 months duration, then bleeding parectum of 5 months duration. But however, in this particular patient, they all occurred the same time. So you should note that presenting complaint without mentioning the duration is incomplete. Now, classical presentation of a patient with rectal tumors or colonic tumors is change in bowel habit. If you are in an exams, you should know the commonest complaint a patient will have with colorectal tumors is change in bowel habits. They might present also with bleeding per rectum, but don't forget, alteration in bowel habits is the commonest symptoms patients with rectal tumors or colon tumors present with, okay? So let's now go to the history of presenting complaint. You should know that history of presenting complaint, the aim of your history of presenting complaint is to characterize the symptom. The history of presenting complaint, the main aim is to characterize the presenting complaint. And what you should know, an adequately presented history, especially the history of presenting complaint, should be able to tell you the diagnosis of that patient. It should be able to tell you the extent of the disease. This extent, in other words, what we mean is the complication of that disease. A good history of presenting complaint should be able to tell you the etiology of that disease. And it should be able to tell you differential diagnosis. Then you also mention the care a patient received. Now, most of the time, you see history of presenting complaint as summarized using the C's, the 5 C's. History of the complaint, okay? The cause of the disease, the cause in terms of etiology, and the care the patient receives. But usually, to be more precise and prevent any confusion during history, you should have all these at the back of your mind. That history of presenting complaint should be able to tell you diagnosis, extent, etiology, differential diagnosis, okay? And of course, you can summarize that as deaths. This is systemic review. So we said your history of presenting complaint should be able to give you a diagnosis. It should tell you the extent. Now, when we talk about extent, we mean complication. And you should know complications, especially in malignant conditions, are classified basically into 3. And when presenting history, you should be seen demonstrating such that a complication can be local, it can be a locoregional, and it could be a systemic. It could be a systemic complication. Okay? So you should know when describing extent of a disease or the complication, it can be a local complication of the affected system. It could be a locoregional complication, and it could also be a systemic complication. We will demonstrate that from the history we just took from this patient. Then the etiology. This etiology is the risk factors of that disease. Now you understand the reason why we have to present the pathology of that colorectal cancer before taking the detailed history. The truth is, if you don't know the pathology and presentation of a disease, you won't be able to give a detailed history, because of course you need to know the risk factors for that condition. What are the risk factors? Because they must surface in your history. So without understanding the risk factors of the disease you are clerking, you might miss out a lot of points while taking the history. So this etiology here, it's represented by the risk factor. Then differential diagnosis, okay? Because you have to look for other diseases that are similar or may have similar presentation with colon cancer. Now, this systemic review, the aim of systemic review generally is to look for other concomitant conditions which may be present. The aim is to look for other concomitant conditions that may be present, okay? But of course, you should know that sometimes when you take a detailed history and you've exhausted the extent, okay, you might have gone through all the systemic review, and the systemic review might not be contributory to your history, okay? So that is how the history of presenting complaint should basically be presented. Let's go back to our history and reanalyze what I just presented so that we'll follow, okay? So we've talked about the history of the presenting complaint. Now, the history of presenting complaint. I said he was well. I want to characterize the presenting complaint now. He was well until 18 months ago when he developed change in bowel habits, which is characterized as constipation alternating with diarrhea, okay? This constipation is for about 3 days. Now, since the chief complaint here is constipation alternating with diarrhea, what do you mean by the constipation? He doesn't go to, this particular patient have constipation for about 3 to 5 days, as opposed to his previous daily passage of stool. Now, this constipation now will be followed with, okay, diarrhea, okay? But he spent 3 to 5 days without going to the toilet. And even the stool he passes is pellet-like stool, just like pellets, okay? When a patient has colon cancer and there is narrowing of a segment of the colon, okay? Let's say there is a tumor here. And when stool comes, there is stagnation. So the stool that passed this might now be in pellets. They fall and accumulate in the rectum as multiple pellets. So as they accumulate to a quantity that will stimulate defecation reflex, when they are passed out of the rectum, you now see them coming out as pellet stool. This pellet stool is described as this rabbit's or camel stool you see, or goats. You see them passing pellet-like stools. Now, pencil-like stools are usually in the rectum because of narrowing of the rectum, or down the anal canal. You see a very thin stool, pencil-like, okay? That is described as pencil-like stool. Now, usually, as we mentioned, in patients with colon cancer, okay? In patients with colon cancer, because of the stasis, as we describe in the pathology, okay? Because of stasis, there is bacterial proliferation, okay? And this bacterial proliferation will lead to liquefaction of that stool, and the stool will now pass out as a liquid, as a diarrheal stool. So that stage where there is constipation, there is stasis. Okay, the stage where there is stasis, they will have constipation. As bacteria ferment and liquefy the stool, it becomes watery and is passed out as diarrheal stool. So that's why they have constipation alternating with diarrhea. So that is the basis for that form of presentation. Okay. Now, usually mucus producing tumors in the rectum or in the colon, they produce a lot of mucus that accumulates in the rectum, and usually in the mornings they pass large amount of mucoid stool. It is not diarrhea, but it's a large quantity of mucus that is secreted from the tumor. It is called spurious diarrhea. All these presentations are classical of a patient with tumor. But from what I said so far, it has not really differentiated whether this tumor is a colonic tumor or a rectal tumor. Now, what really differentiates them is tenesmus. Tenesmus, when you say a patient has tenesmus, you have localized the tumor to the rectum. Because tenesmus is a symptom that is characterized as persistent urge to defecate. There is a persistent urge to defecate. And this urge is usually fruitless. That is associated with passage of little or even no stool or mucus. So patient will have persistent urge to defecate, which is fruitless, is associated with little mucus or even no stool. That is called tenesmus. And why is that so? Why is it that it is rectal tumor that has tenesmus? Because in the rectum, okay, if there is a mass in the rectum, this mass will persistently stimulate defecation reflex. It will persistently stimulate defecation reflex. And of course, because it's a mass, it cannot be passed out. The patient will have a persistent urge to defecate, which will not be producing anything but the mucus that is being secreted by the tumor. So that is tenesmus. So you should know, any time in a history you mention that a patient has tenesmus, you have localized that tumor to the rectum. It is now a rectal tumor, not just colonic tumor. Now, you can see the next part of the history says there is associated tenesmus, which is so frequent to disrupt his routine activity. Now, most of the time, patients with tenesmus, you will see them, it is so worrisome that they will have a commode or a toilet pan under their bed. They are so tired of going to the toilet because of that frequent urge to defecate. And when they go, they don't pass anything. Now, anytime a patient has tenesmus, there is a mass effect in the rectum. Mark you, sometimes a patient with dysentery caused by shigellosis or a form of amoebic dysentery or shigellosis may have these symptoms of tenesmus. They will be having frequent urge to defecate, and when they go to the toilet, they pass a small quantity of mucoid stool. So what is actually happening? There is no mass and they are having tenesmus. What happens is the shigellosis stimulates inflammation in the rectum and the mucosal edema. Okay, there's mucosal edema, and the edema will now have a mass effect with a constant stimulation of defecation reflex. Now, so we've described the change in bowel habit and we have localized the disease to the rectum. You see how the history goes. Then the next presenting complaint is bleeding per rectum. Now, the bleeding per rectum, during the lecture, we said that the type of bleeding determines where the bleeding is coming from, whether it's a bright red, whether it is a blood that mixes with the stool, or whether it's a blood that coats the surface of the stool. Now, at about the same time, he noticed bleeding per rectum of bright red blood, which coats the surface of the stool. No passage of clot. Now, there are two important statements here, or let me say three. One, we said that this bleeding is bright red. Okay? Two, it coats the surface of the stool and no clot. So now what you need to understand here is, since it's bright red, there is no, it has not been altered, okay? It has not been denatured, it has not been digested by enzyme. And since it's coating the surface of the stool, it's not far from the anal vag. This bleeding is not far from the anal vag. That's why it has not gotten enough time to mix completely with the stool. And the rectum is just 12 to 15 centimeters. So if the bleeding is coming from the rectum, it will coat the surface of the stool. It has not gotten enough time to mix with the stool. And there is no passage of clot. That means it's not large amount of bleeding, okay? Now, you see, at about the same time, he noticed bleeding per rectum of bright red blood, which coats the surface of the stool, no passage of clot. Now, this coating the surface of the stool, at the same time, patients have tenesmus. Because in your exams, they will be asking you from your history what suggests rectal tumor, okay? You see, tenesmus has localized it to the rectum, coating the surface of the stool, meaning it has not gotten enough time to mix with the stool, so it's likely a rectal tumor. Now, since onset of these symptoms, okay, there is associated weight loss, which is asthenia, easy fatigability caused by anemia, and anorexia, the 3 A's of malignancy. So, if you look at this presentation, this patient has change in bowel habits, okay? Diarrhea alternating with constipation, which signifies that there is a mass in his colon. We now localized it that he has tenesmus. We further localize that this mass we are talking about is in the rectum, okay? And it is bleeding. And finally, we now said this mass has features of malignancy. So this history of presenting complaint at these first few statements, okay, these 4 major statements in the paragraph here have characterized a mass in the rectum that is likely malignant. So we are done with the first part of the history of the presenting complaint, which is what? D, diagnosis. Now, from this small presentation, you have already made a diagnosis that this patient has a mass in the large intestine, and this mass is in the rectum, it is bleeding, and it has features of malignancy. So it's likely a rectal tumor. So the next thing we want to achieve in this history is to define the extent. Since we said this is a rectal tumor, the next thing, how far has it gone? That is the extent now. How far has it gone? What are the complications this patient already has? So let's go back to the history of presenting complaint. No abdominal distension, pain, or bilous vomiting. These are features of what? Intestinal obstruction. Why am I starting with this? We said extent are local, and when we say local, it is the bowel itself. Okay? It has to involve the bowel because that is the primary site where the tumor is arising from. No anal pain, protrusion, fecal incontinence, no perianal discharge of feces and flatus. The next complication, okay, we said anal pain. This is very important history when taking history of rectal tumor, because you must, in your history, differentiate, you must differentiate rectoanal tumors from anorectal tumors. When you say a patient has rectoanal tumor, it is a tumor in the rectum that spread downward to involve the anal canal. And how do they present? They present initially with features of change in bowel habits, okay, followed by pain. Why is that so? Because the anal canal has somatic innervation where they will have pain. So the rectum has visceral innervation. Initially, there is no pain. There are just features of obstruction from change in bowel habits, which will now, when it encroaches the anal canal, it becomes painful. So it is what? A rectoanal tumor. So during the course of your discussion with the examiner, he asks you, how do you differentiate whether this tumor started from the rectum or it started from the anal canal? You will tell your examiner that it started with features of obstruction and later he developed pain. That signifies that it's a rectoanal tumor. But when it starts with features of pain before obstructions, symptoms of obstruction is what? Anorectal tumors, because the anal canal has somatic innervation. Now, if you go back to the next complication, it's still local. We are still talking about local complication. The first one we talked about is intestinal obstruction. Now, the next one, if it encroaches the anal canal, you will have anal pain, because that is still a local, becoming a locoregional now. From the local, involving the bowel wall and the lumen, it's becoming a locoregional. And as it involves the anal canal, it can invade, okay, the sphincters, and patient will have fecal incontinence. And from there, they can even have fistula, perianal fistula, okay? So you can see now we are moving to regional. Locoregional, we say pain, anal pain, incontinence. It has involved the sphincter. Okay, then fistula in anu. No history of fecoluria or pneumaturia. No history of fecoluria or pneumaturia. Now, when these tumors invade the bladder, the urinary bladder. They form a rectovesical fistula, and they will have fecoluria, passage of feces in the urine, and pneumaturia, passage of gases in the urine, because there is now a connection between the rectum and the bladder, okay? So feces will now pass and it will go out through the urine. Fecal particles will also be seen in the urine. This is also a locoregional complication, bladder involvement. Now, I told you yesterday that these tumors can rest on the ureters. And when they rest on the ureters, they will cause hydronephrosis, hydroureters, and even they can present with what? Infection. So they will be having flank pain, swelling, and fever from the stasis. So that's why we said no history of flank pain, swelling, or fever. These tumors could metastasize now. So we are done with locoregional. It could involve the word ureters. The next is history of jaundice, cough, chest pain, difficulty in breathing, okay? Now, you can see this is metastasis to the liver. So the next extent is systemic. When you say jaundice, it has spread to the liver. Cough, it has spread to the chest, okay? Chest pain to the bones, the ribs. Difficulty in breathing, okay? You can see the chest involvement has developed. It has gone to an extent of even having a pleural effusion, okay? Now, occasionally he has palpitation and dizziness. You can see the patient is already having what? Anemia. It's a systemic manifestation. No bone pains or back pains. So it has not metastasized to the bone, no headaches or convulsions. Now you can see the only systemic involvement this patient has is palpitation and dizziness, which is anemia, okay? So we've taken history of extent. If we are to revise from what we discussed, we said this patient, from what we got a diagnosis of rectal tumor that is malignant, and the positive extent we got from this patient is anemia. All other extents, system and complications are negative. So the next part of our mnemonic death is etiology or risk factors. So we go back to the history. No history of rectal bleeding in the past or colonoscopy. If you follow the lecture carefully, the risk factors we mention: benign lesions, adenomas. And usually adenomas, they will be having rectal bleeding in the past, but they don't have those 3 A's of malignancy. This may warrant frequent colonoscopy for diagnosis and biopsy to confirm that they have benign lesions. No history of rectal bleeding or colonoscopies in the past. When you hear such things, you are looking for what? History of adenomas, okay? No family history of similar problems. We talked about genetic risk factors, okay? We talked about HNPCC, where we even discussed the Lynch 1 and the Lynch 2. We said Lynch 1 is tumor, colon cancer specific. Lynch 2 is cancer family syndrome, which we outline all this. So no family history of similar problems, colon, ovarian, breast, or gastric CA. No history of exposure to radiation. We said therapeutic radiation for prostate cancer is a risk factor for rectal cancer. His diet, we discussed extensively about diet. So you have to mention the predominant diet in this patient. Diet is predominantly cereal-based, which is not a risk factor. And this is even having a high fiber. So you can see this is not a risk in terms of that. He does not smoke or ingest alcohol because we are dealing with malignancy here. Smoking and alcohol will feature in the history of etiology, not in social history. Okay, so this we all describe the various, some of the risk factors and the common ones for colon cancer. Okay, now if you go back to the history, okay, if you go back to what we described, we've described etiology now, or risk factors. The next is differential diagnosis. What are those common conditions that present like colon or rectal tumors? Now, no contact with chronically coughing adults or drenching night sweat, tuberculosis, TB, okay? Tuberculosis of the large bowel will present with features that are similar to colon or rectal cancer. Now, irrigation farming or childhood hematuria, you are talking about what? Schistosomiasis. Okay, so we've mentioned one differential diagnosis, tuberculosis, two differential diagnosis, schistosomiasis, no history of diarrhea associated with febrile episode. This is amoebiasis. No frothy diarrhea, okay? These are what? Inflammatory bowel diseases. Now, in surgery, you are not expected to be bringing so many differential diagnoses, at most 4. The 4 common ones, 3 to 4 are enough, okay? Because you have to give differential diagnoses that are close and similar to the presentation. So we've talked about the common differential diagnoses that are similar. All other aspects of the history will be similar to other aspects you are already used to. The past medical history, no, not a known hypertensive, diabetic, asthmatic, no previous surgeries or blood transfusions, since onset of symptoms. We've all discussed this. You have to complete the other aspect of your history. Then you now summarize. In the summary, you mention the age of the patient, which is a risk factor, his constipation, the chief complaint, alteration in bowel habits, tenesmus, bleeding rectum, progressive weight loss, dizziness, palpitation, and easy fatigability are features of anemia. Okay? So now you can see this summary highlighted the important positive for a patient with rectal tumor. Look at his age, okay? The 6th decade of life, okay? The alteration of bowel habits, you localize it to the rectum and he's bleeding and he has weight loss with anemia. Now, most of the time in your presentation, the examiner will ask you questions after the history. The questions after the history that normally comes, what is your diagnosis? What is your diagnosis? Now, from what we presented, my diagnosis is rectal tumor. You will say rectal cancer, of course, because it has features of malignancy, complicated by anemia. The next question the examiner will ask you, from your history, what suggests your diagnosis? This patient is a 65-year-old male. This age is commoner for rectal tumor. Rectal tumors are commoner in males than females. That is 2. He presented with alteration in bowel habit with associated tenesmus. That tenesmus signifies that this tumor is originating from the rectum. And there is bleeding per rectum, which coats the surface of the stool, which means the bleeding is coming from the rectum. Now, he has associated palpitation, dizziness, and easy fatigability. So these are the features that brings out the point in your diagnosis, and this determines whether you pass that history or you do not, okay? So this is very important, okay? You boldly and confidently answer the question, highlighting the reasons from your history that suggest your diagnosis, okay? This is the commonest questions that are asked after taking a detailed history, okay? So the next thing, they may ask you, at what stage do you feel this patient is presenting? Is it an early disease or an advanced disease? Okay, since it's already becoming a systemic problem, okay, it's likely an advanced disease. So because of time, we are going to divide this into 2 so that we will also discuss the examination in detail. So I'm going to stop here so that I will give you chance to ask questions and clarifications so that we don't take too much of the history. And when we take too much of the history, we might have challenges in grasping all the explanation that are given. So now, if you have any questions, clarifications, please, you can unmute yourself and ask so that we discuss. So please, any questions, clarifications? You can unmute yourself and ask. Okay, it appears that there are no questions. So because of time, okay, I don't want it to go longer than this. I'll allow you, maybe when we come to discuss the examination, you must have gone through what we discussed, jot down your questions. Then you will ask questions. Then we go to the examination and you see how other parts of the exam goes when you are presenting a long case. So thank you very much. We are going to stop here, and probably tomorrow we will continue with the examination parts and the questions that normally follow. Or do we have anybody with a question?
Thank you, sir.
Okay, it appears there is no question, but because of time, I don't want it to be too lengthy. We are going to stop here, and probably tomorrow we'll take the other part of the presentation. But it is important for you to understand that for you to give a very good history of a long case, you must understand the pathology in question. You must understand the mode of presentation of what you are discussing, okay? So thank you very much. We are going to end the presentation here.
Thank you, sir.
Okay.